Ashwin, hello, sir. Dr. Vasan. Let's start. Let's give you the title you've earned. Dr. Vasan. How are
Great to
you?
see you. Good to see you. Good to see you. I'm doing very well. Yeah. I hope the
Likewise,
summer's going well
likewise.
for you.
It's going very well.
Good.
Doc, let's start. I want to take a step back. 5 years since COVID. Um, and you're an epidemiologist, and I hope I pronounced that right because
Yeah.
but I want to take a step back and I want to just sort of mix in government with policy because you do both, right? And medicine in your case. I remember once upon a time when I worked at the Department of Education and we had a town hall in Maspeth in Queens. And here's why it stands out. That was a time when the certain communities had an issue with the reform of the specialized high school exams in New York City, meaning Stuyvesant, Bronx High School of Science. And at that time, the administration, the de Blasio administration, wanted to make it multiple measures as opposed to the one test on one day, which is the current standard. What happened was the chancellor was getting a lot of grief from parents that did not agree with that, right? That wanted to keep the things in the policy the way it was. But here's why this is tied into COVID. I remember this was at the time right before shelter in place when people would say, wash your hands and sing happy birthday, cough into your sleeve. Uh, but here's what stood out. There were a lot of parents who were East Asian and they all had masks. No one else was wearing a mask, but everyone that I saw there stood out. I just found it because I was like, why are they wearing masks? Um, and then I remember at that time in history, uh, we were told early on during COVID not to wear a mask. Now, all this ties into what going back now. Let's take a step back. We were told, support certain communities, support certain businesses, keep going with the flow, keep doing what you're doing, and make sure you don't call. The that was the protocol back then. Now, tell me what you think early on was missing in terms of the response. This is just your own observation again as an expert in the field, and I want to tie that into where we are today, right?
Sure. And look, it's so good to be with you. Good to see you after all these years. Um, Look, like every New Yorker, every father, parent, community member, I experienced those early days of COVID like everyone else with a lot of anxiety, some fear, uncertainty. And so I remember those days very clearly on a human level. I also remember it as a nonprofit leader at the time, as a clinician who was getting called back in. There was not only sort of fear and worry, but also a sense of civic duty to really step up for my city, step up for my neighbors, for my community. And then there was also just a lot of knowledge gaps. There were just things we didn't know. And that's from as high as international authorities, federal authorities, trickling down to the city as well and states. We just didn't know a lot about this virus at the time, and the information was shifting every day, right? New information was coming in every day, new studies, real world studies from China, from Italy, from places that had gotten hit just before us. And
Mm-hmm.
the last thing I remember from those very early days is just how painful that time was. We lost 50,000 New Yorkers, New York City residents to COVID. And half of those were in the first 3 months. So just think about that. I mean, like that is over 10 times, much more than 10 times the current, like the death rate on a daily basis, right? And you're basically traumatizing a city in a very short amount of time. No other city in the United States, let alone very few in the world, experienced COVID like New York City did. Densely populated, highly vulnerable, lots of in migration and out migration. So all of that is to say, those were very difficult times. And so obviously I was advising and helping as much as I could. I was running my own nonprofit Fountain House, which we shut
Yes.
down before the
Hmm.
city, and which I think was very clearly, it clearly saved lives because these are really vulnerable people. We shut down about a week before the city. And, you know, I have an appreciation both from those moments, but also subsequent years and the role that I ended up in, for how difficult those decisions were at the time. Right now, I think there's so many lessons to learn from that time, not just those early days, but the entire response. But rather than start to talk about like what we got right and what we got wrong, I think it's just important to set the context of like what we knew and what we didn't, right? And I think that makes this qualitatively different than the kind of thing you discussed with the SHSAT, right? Because that's real objective data that you have from years prior on students and performance and demographics in a system that's tightly controlled. This was a novel virus out in the world, out in the public, moving in ways that we didn't fully understand at the time. And yeah, there were some groups that kind of caught on early from past experience. East Asian communities, particularly new immigrants, as you described, wearing masks, that comes from successive epidemics of things like SARS,
Mm.
the first SARS virus in China and Hong Kong, from things like MERS, the Middle East respiratory virus that hit parts of Iran and other places. You know, I think around 10 years, 11 years back. So there are communities that saw that there were common sense things you could do. And, you know, at every level of government, I think we could have been faster. And I think, and also the structures of how we interrelated to one another. I know there was like a ton of deference given by New York City and by cities and states across the country to the CDC. And the CDC at the time was just like not ready for prime time,
Mm.
right? They were not ready, which successive CDC directors and staff have acknowledged, right? Then they've used it as a chance for reform. So that would be my overarching kind of view of those early days. Is like we didn't know a lot. There were some things we did know. We could have moved faster, but I think everyone was doing their level best to try to make things work.
Thoughts on Dr. Fauci? He received, again, depending on what side of the political spectrum you're on, he received a lot of credit for the national response, and you know, sort of became, again, on at least on the Democratic side, a sort of a folk hero. What are your thoughts on some of his, again, the things he did at a national level? I know he was pushing hard for the vaccine and the timeliness of the vaccine. What are your thoughts on him?
Look, I mean, Anthony Fauci is a friend, a mentor, a hero, and has served Republican and Democratic presidents for administrations for 40 years, more than 40 years in federal service, right? Working his way up through the NIH, going through multiple pandemics, HIV, um, being very open about the things he's gotten wrong and gotten right, you know, in that service. And I can't believe, I mean, I totally understand your question, but the fact that we're talking about him as like a Democratic person or a Republican person, this is a doctor. Like this is a
Mhm.
doctor's doctor, you know,
Mhm.
someone who you want providing that scientific expertise and that clinical expertise. And the fact that it's become so polarized and politicized is just a really sad state of affairs and speaks, I think, to that deep lack of trust that has built up over time against healthcare, against public health, against government and authority. And sadly, I think Tony has been at the sort of the forefront of that for the last several years with COVID. And honestly, you know, you may not remember this, but I experienced something very similar at a smaller scale, right? In the early days of my tenure as health commissioner in New York City, I was having protesters at my home when we started to pull down the mandates. I had protesters at my home multiple times a week for 7, 8 months. I needed police detail. I got restraining orders on a couple of them. They were making threats against my life. They doxed me on social media. They showed up outside my home. They even planned a huge protest such that the NYPD shut down my street one evening. Um, you know, it's a crazy testament to the state of affairs in our country and in our civic discourse, where a person like Tony, people who come into this work out of a sense of public service, out of a sense of how to use their expertise and their training to help people, um, are so deeply politicized in that way. But it is not. It's real, right? It's happening. It's happened, and we have to reckon with it. We can't put our heads in the sand and say, "Gosh, I wish we could go back to the days where doctors could just be doctors and scientists could just be scientists." Sadly, the whole field has been broken open, and trust is so low that we've got to rebuild that brick by brick.
Ashwin, talk a little bit about Fountain House. And the reason I wanna start there is because people conflate some of the stuff that's happening in the subway system and in the city, people not receiving the treatment that they need in some cases, people with severe mental health issues that can't take care of themselves and need help are now, unfortunately, in some cases, acting erratically and doing things that. But I know that you have you ran a program, and I think you're there again. That's sort of a national model in treating people and also transitioning them. But I want you to tell people what it is and what it isn't, and I also want to sort of have you lean in on your thoughts on treatment. How do we help these people? I know that the mayoral primary, everyone seemed to have had a plan, a policy plan on more beds, more long-term treatment, you know, pointing the fingers. It was the state's fault because they cut back and so forth and so on. But again, I want to hear your thoughts. I want you to talk about Fountain House and the way you went about, right? I don't know if this is called figuring it out, but you know what I mean, getting people the supportive
Sure.
wraparound services that they need. And I
Yeah.
remember going back to my time at the DOE, the sort of community school model,
Hmm.
where again it's wraparound services for some of these kids and that don't have, or in some cases, right, need additional help than what they're receiving in the classroom. But again, I
Yeah.
want you to sort of talk a little bit about the work of Fountain House and talk about the mental health crisis in the city.
Yeah. And we made this a huge priority of particularly my early tenure, but throughout my, 3 years as health commissioner, this was always a focus was mental health, serious mental illness, youth mental health, overdose crisis as the three pillars of our mental health plan. And it's good to see those things being followed through on in different ways. Um, Look, I mean, let's step back for a second. Like, if you think about the crisis of serious mental illness, there are about 14 million people in the country that have serious forms of mental illness, and there are somewhere on the order of like, 250 to 300,000 in New York City. Okay. The vast majority of those people you don't see, right? Because they're not out on the streets. They're living amongst us. They're living in homes. They're not all disabled, right? Mental illness is a chronic illness that goes up and down. Now, prior to the 60s, most of those folks would have been in a mental health asylum, right? And then John Kennedy passed the Community Mental Health Act of 1963 and started to slowly draw down the asylums. And we saw that happen in New York City as well. Willowbrook and other places
Yes, yes.
were closed down, and rightfully so. A lot of those places were treating people quite poorly, but they served one purpose, which was to at least create a sense of safety around these folks, even if they were, had lots of reform to do. But we closed those places down, well intended, but we never reinvested in a community mental health system to build back up. How do you keep people in the community, keep them stable, keep them connected? And in 1948, a group of people who had just left Rockland State Psychiatric Hospital got together and said, like, what do we do now? They're back on the streets of Manhattan. They're they're living their lives. They can't get a job. They can't get back to work. They're on some benefits. But at that point, 1948, there was no Social Security, right? There was no Medicare or Medicaid, right? So they're just struggling. And so they said, well, we're going to do what other people do is create a members club. We're going to create a community for ourselves where we can get together, where we can come together and actually do things together, and we can run the place. And then with it, came services and counseling and staff, and build up these ecosystems where people can kind of come, and it's an anchor institution in their lives. It's one of those places that gives them both purpose and community, and it's also an early warning system when someone's falling off, right?
Mm,
Like it's a
mm.
place where, hey, Roberto didn't show up for the last week, let's go to his house and find out. And over the many decades that Fountain House and the clubhouse model has existed, um, it's connected up into things like supportive housing, into psychiatric care, into clinical care. Now, so it's a powerful model that has been in many ways hiding in plain sight. New York City is actually the city, because it's the originator city, has the most clubhouses in the country, but there are only about 200 of these clubhouses across the United States, and they're very small. In the Fountain House is the largest. They're very small, and there's another 100 around the world. So there's something powerful in the model that people deeply understand, that people need this purpose, they need a place to go, and they need people who will form community around them, right? So when we were thinking about this as a city, we said, okay, how do we bring this model into the 21st century? How do we invest more city resources into it? How do we expand it? How do we get it connected up into things like Medicaid and Medicare and housing? And so that's a lot of what we did. We, during my tenure, we doubled the budget for clubhouses. We professionalized them by creating performance standards and metrics to kind of track outcomes. We expanded the partnerships with housing and clinical care so that these clubhouses are connected into hospitals and into housing, supportive housing projects. And so we're on our way, but it's going to take quite a bit of time to really turbocharge this and to build it up. And so this is the kind of community mental health infrastructure that we've needed for a very long time, and that can serve as a place for people to go instead of going to the subways, instead of, finding themselves in dire straits on the streets. Um, these are anchor institutions that are supposed to create stability in combination with housing and medical care. So we have a lot of work to do there, but I'm very passionate about it because I've seen it work. I mean, the people who Fountain House serves and clubhouses serve, about 40% of them have a history of homelessness. Another 40% have been hospitalized in the last year. About 20% of them have been incarcerated. And on every metric, you see those things drive down to under 5% or close to zero within the first year to 2 years after joining one of these clubhouses. So this is a powerful model, but it needs to be modernized and brought into the 21st century. And so, as you can imagine, that kind of takes some effort. I'm not with them anymore, but I'm always going to be a fan and a champion of this wherever I go, because I think it's a real missing national piece of our community mental health system that can serve these, as I said, 14 million people around the country.
Talk about that, intertwine that with the city of New York and the response that the city's taking, right? And some of the recent policy. I know Health and Hospitals rolled out something where they were creating or a space for people to sort of transition them, because supposedly the number of actually street homeless that have severe mental health, not one is too many, but it's not a huge number.
It's not. And this speaks to what?
Mm.
It speaks mostly to fragmentation, right? Like it speaks to the fact that we put another band-aid upon another band-aid upon another band-aid. And then you've got like multiple administrative cracks in the system that people can fall through. So it's like I'm handing the patient off to you, to you, to you. It doesn't work. So part of why clubhouses work is because you create this holistic as you say, wraparound model, which is talking about clinical care and housing and benefits and lifestyle and mental health and employment and education opportunities. So it's a bunch of positive things as well as trying to prevent a lot of negative things. We've got a lot of players in the city. New York City does not lack for resources, right? It's not a money question. It's an allocation of money, and it's a
Mhm, mhm,
prioritization and a
mhm.
political will
Yeah,
issue.
yeah.
And
And
so
maybe some uniformity too. Sometimes there's silos in government.
there's silos in government, but if a mayor or a deputy mayor or anyone took this as a real charge and said, we are going to do this, I was empowered to do it to the extent that I could as commissioner, but I only ran one agency, even though health commissioner has a larger bully pulpit. I only ran one agency and I only could really move around the resources
Got
that
it.
I could.
Got it.
So
Got it.
it really needs political leadership to say, this is going to be our model. This is how we're going to build. We're going to create unified systems around these most vulnerable people. And to the credit of the current administration, they tried really hard with things
Mhm.
like the top 50 list and subway outreach and multiple iterations. And I give them credit on the front of like constantly learning, constantly trying to improve this system, which is really foundationally in many ways broken. Um, but it's not going to be an easy thing to do. We tried we tried housing first. We did a small pilot of housing first in the first year of our tenure. It went really well. We had 80 people who got immediately placed in housing, but it requires that follow through to kind of say, all right, now that's going to be the policy of the city of New York. And so with anything, changing healthcare policy, changing mental health policy, changing public health policy, it requires political will. It requires attention from leadership, and it's my job to get people's attention. But at some point, you gotta have the force of will to follow through.
Got it. Ashwin, let's talk about opioids, the crisis with opioids, and it's sort of, I remember working, and you're familiar with it, with the clinics on 125th Street. There's the open injection site up in Washington Heights and 126. Talk about that and your thoughts on that in terms of the policy, because now the state Oasis is getting a lot of pushback in some cases, claiming
Yeah.
that there's an oversaturation of clinics in that 125th Street corridor, which is tied to, again, quality of life issues, which is tied again to name it, right?
Yep.
In some cases, NIMBYism. What are your thoughts on the response
Mm-hmm.
the epidemic as a whole, right? It's a lot of overdoses happening.
Yeah.
And I want you to lean in on that and your thoughts on that.
Well, here's what I would say. Let's start with the good news. The good news is that in my last year, well, in 2023, the last year we have full data for, we saw the first downturn in overdose deaths that we've seen in nearly a decade. So that shows that our strategies are starting to bear fruit. Strategies like widespread adoption of naloxone, distributing naloxone anywhere and everywhere, combined with the previous administration, the federal administration's effort to make naloxone over the counter. We as a city were distributing over 300,000 naloxone kits, 2 doses per kit, all across New York City. So that starts to bear fruit. I'll focus on things like harm reduction and syringe service providers, making sure that drug use doesn't take place hidden away in the shadows, but rather can get brought out into the light where people can get connected into services. The majority of overdose deaths happen in isolation, happen alone, amongst people using alone. So we want to bring those people out to say, all right, look, we know it's not great that you're using, but we'd rather you use in a safe environment. And that gets me to those OPCs or supervised injection sites, which, I on one level, we know they work. We know they work from other settings. We have plenty of data from around the world that these are effective sites. And we now have data locally as well that they work, that they haven't had any overdose deaths, that they have minimal to none 911 calls, that they connect people into mental health treatment, into substance use treatment, into basic primary care, into meeting basic needs like food, shelter, clothing, all those things. But a policy like that, a program like that, cannot be a pilot forever. You have to scale that up quickly and make it the policy of the city of New York or wherever to have supervised injection or not. Because
Mm.
keeping those 2 sites hanging out there just puts a target on their back. And it's not fair to them. It's not fair to their clients. It's not fair to the communities around them. Because Oasis is right. Those communities are oversaturated. And it has become a self-fulfilling prophecy because if you put all the services in one neighborhood, then people are all going to congregate to that neighborhood. Good people, people who need help, and the people who are taking advantage of those people too, dealers and criminals and other folks, right? People interested in criminal activity. It's not fair to the 125th corridor in that neighborhood. It's not fair to areas in Washington Heights, but it's a It's not fair to the folks in the South Bronx who haven't had those services. Um, but it is a product of us doing this piecemeal drug policy for too long. You can't pilot your way through success. You got to decide, like, this is our comprehensive strategy, and be brave enough to say, I'm going to see this through. Once again, I'm constantly talking about deciding to do things and seeing them through, because that's like what political leadership is missing these days. And so I those two sites now are under attack because of an inability to scale them up quickly, which was always the intent. If you look at our mental health plan, we wanted to build 5 more right away with the opioid settlement dollars that we were getting from the state. Unfortunately, then you had the DOJ saying, the previous DOJ saying, you know, we might have to raid the sites. In an election year, like, how are we letting this happen, right? So it all became highly politicized very quickly, and it put a hamstring on experts like my team, my former team, and the people doing the work in the community, like On Point NYC. That's the fantastic organization that runs those sites. I mean, what are they supposed to do in that context? They're just trying to survive and trying to do good. So um, I chalk most of this up to a failure in leadership on so many levels, right? Because if it was just fear based, right, at the end of the day, like, you could have said, we have a year of data, now we push, right? But we got mixed messages from everybody, from the DOJ, from the state. And so it puts the city in a very difficult position. Like, what are you supposed to do in an election year? What are you supposed to do? It's a very hard political choice. And unfortunately, I think the people who lose out are some of the most vulnerable New Yorkers at the end of the day, who need our help and who are going to now, I don't know what the future of those programs is. I hope they stick around till we have the ability to grow them further. But in this current environment, it seems like a very difficult and unpalatable set of solutions, at least from a political standpoint.
Ashwin, I want to wrap this up because I don't want to keep you longer than I know you have other things to tend to, but I want to go down my countdown list.
No, okay.
Top 3, now top 3 in terms of the city of New York, top 3 health issues in terms of what do we as New York City residents have to be on the lookout for our own holistic well-being day to day. What are the 3 concerns you have as a medical doctor? Is it obesity? Is it childhood obesity? Is it diabetes? Is it heart disease? What would you say are the top 3?
So I would say number 1 is actually affordability of care. Um, you know, we canceled $2 billion in medical debt under my watch. And that's just a drop in the bucket for the kind of debt that people are saddled with. Now we have 1.5 million projected New Yorkers who are going to lose who are going to lose Medicaid coverage due to the federal budget that just passed, and at least half of those are living in New York City. So we're going to have hundreds of thousands of people who are going to now be without a lifeline for healthcare, which means they're going to delay care. They're going to wait till go to an emergency room when they're really sick. They're going to be saddled with more bills, and it's going to cost the whole system a lot of money. So it's not only morally objectionable and human from an ethics and human standpoint, but also from an economic standpoint. It's just like bad economics to kick that many people off coverage. So I think affordability and access to care is really crucial. And I think the time is now for the state, in particular the state, to really step up and think creatively about solutions to both expand state-run coverage and access, but also to take the Medicaid program as it is and really shift it away from just care and the volume of services provided towards prevention. And I wrote a daily news piece recently on this. I think that's a real opportunity. Whatever you think of the president right now and his administration, and mostly I'm thinking negative things, he's bold and he's getting things done towards his agenda, his view of the world. Democrats and elected leaders in New York need to get bold. And Medicaid is one of those areas. It's 43% of the state budget. We better get bold on how to reform that program. And we need to not only find new revenue sources, things like a sugar sweetened beverage soda tax, I think raise $1 billion a year just as a start, but then also cutting programs that really aren't delivering value across the budget and finding that ability to replace it with a state-run health program, but also taking that entire program and shifting it, Medicaid, towards more prevention. We had a Medicaid waiver, a Medicaid basically flexibility that was passed last year as a pilot. Time to blow that up under state authority, right? Time to expand that, scale that up rapidly. So there's lots of ideas on how to do that, and I outlined some of those in that op-ed. So affordability is number one. Number two, I think it's nutrition and diet-related diseases, particularly as they affect young people and children, because childhood obesity is on the rise, particularly amongst low-income Black and brown youth in our city. There's these concentrated food deserts and concentrated areas of both poverty and poor health, obesity, and poor diet and poor access to food. So, we really need to push on our food systems transformation. I give a lot of credit to things like the plant-based meals in hospitals as the default option. It seems like a small thing. It's actually a big thing because New York City is the second largest purchaser of food to the US military, right? So you can really shift norms that way. So really changing our food systems